Good evening, everyone. Thanks so much for joining us for this Zoom conference. It's always crazy to realize that we're doing a Zoom meeting in this COVID times, but we appreciate your attention, and we're happy to say that we have about 50 viewers, which is exciting. We have an exciting program for you, and we're going to get down to it and start right away. Again, in these times of COVID, it's really can't help but mentioning the impact of it on our practice, and we wanted to just update you with regard to what our practice is doing in response to COVID. All of our doctors and staff are in the process of getting vaccinated. Many of the doctors have actually received both of the vaccines already, and all but 2 of the staff have received their first vaccine. We are limiting the presence of non-patients in the office, with the exception of translators and caregivers. We've decreased office waiting times by separating out testing visits. Specifically, patients who have extensive glaucoma testing are doing that on a different visit from their clinical visit, just to decrease the time they spend in the office and decrease their movement within the office. We're calling patients before their visits to update their histories, rather than doing that at the time that they come to the office, again, to decrease their time in the office. We are continuing to do health screening at the front door, checking patients' temperatures, reviewing their symptoms of COVID, and insisting that all patients wear masks if they want to enter the building. We've decreased our seating in the waiting room to allow for social distancing. We continue to sanitize and clean all the surfaces between each patient. And all patients who are having surgery at Camp Lowell Surgery Center are required to have a negative COVID test within 7 days of surgery. And here we are again doing the Zoom meeting. I did at this point just wanted to thank Dr. Fry and Dr. Lee for coordinating the program and ensuring that you all get your appropriate CE credits for the meeting. And the gist of my talk is a very exciting new technology that I'm excited to share with you guys, called the Light Adjustable Lens. The company that produces it is called RxSight. We acquired this technology last month. We've done 8 patients, but I'm really excited about this and wanted to get everyone up to speed on it. So here goes. What's fascinating about this intraocular lens is it can be customized for its power after surgery. The optical power is adjusted using an in-office ultraviolet light treatment. So the patient gets to try out the vision, see whether they're comfortable with the refraction they have, and if they don't like it, we can actually change it up to 3 times after the surgery has been done. This is one of the company's renditions of how this works going into the photochemistry.
RxSight's light adjustable lens provides cataract surgeons with the ability to adjust the power of an intraocular lens after the lens has been implanted and the eye has healed, with an in-office approximately 40 to 120 second light treatment. Light adjustability of the lens is based on the principles of photochemistry and diffusion. RxSight's light adjustable lens incorporates proprietary silicone photoreactive additives called macromers, which are distributed throughout the lens. When light is directed to a specific area of the lens, macromers in the path of light attach to the ends of other macromers, forming polymers. The remaining unreacted macromers physically diffuse into the exposed area, causing a highly predictable change in the shape of the lens and a refractive power change of the RxLAL. The light treatment can simultaneously be directed to perform spherical and cylindrical adjustments to the lens. As long as there are untreated macromers, further adjustments to refine the correction can be made by applying light to different areas of the lens. When the adjustment process has been completed to the satisfaction of doctor and patient, the entire lens is exposed to the treatment light to polymerize all remaining macromers, effectively locking them in place to prevent any further changes. RxSight's light adjustable lens enables cataract surgeons to precisely reshape the lens based on the exact amount of visual correction and optimization needed to achieve the desired vision after cataract surgery.
So traditionally, when we evaluate a patient for cataract surgery, we obviously have a detailed conversation with them beforehand about what their visual requirements are, what their preferences are. We make a selection and then use our machinery to make all the calculations and measurements. We do the surgery, and in the overwhelming majority of patients, we hit the target and do very well. This lens changes that whole paradigm in that we have the flexibility after the surgery to adjust the sphere and cylinder up or down 2 diopters in either direction, which is pretty amazing. This is a patient video that we have, which is a little more simplistic, but we want to show you what we share with patients about the lens.
The revolutionary light adjustable lens from RxSight is changing cataract surgery by offering you more control, customization, and confidence in your visual outcome. In traditional cataract surgery, your doctor chooses a lens prescription before your surgery without knowing exactly how the lens and your eye will work together after surgery. With the light adjustable lens, your doctor now has the ability to change the prescription of your new lens after surgery through specialized ultraviolet or UV light treatments, giving you the power to fully customize your vision. This ability to change the shape and prescription of your lens after surgery gives you the unique opportunity to test drive different visual outcomes to see what feels best. By test driving your vision, there's no guesswork, and you'll be able to experience and design your best vision outcome with complete confidence. When you choose the light adjustable lens, your surgery experience will be the same as if you had selected a standard lens. The difference is that the customization process begins after your surgery and when your eye is healed. After surgery, you'll need to wear special protective UV glasses at all times to protect your new lens and ensure your best possible vision outcome. You must wear them at all times while you're awake until your light treatments are complete. You'll receive between 2 and 4 total light treatments once your eye has healed from surgery. Each treatment lasts about 90 seconds. And during these treatments, your doctor will reshape your lens to achieve the vision you desire. The number of treatments you receive will depend on the amount of customization you desire, the amount of light used, and your vision goals. 24 hours after your final light treatment, you'll be able to remove the UV glasses and enjoy your new custom vision. The control and customized power of the light adjustable lens is helping patients design their perfect vision. It's the first and only lens to offer this unique blend of control, customization, and confidence.
So the 3 components of the system are the lens itself, the RxSight insertion device, and the light delivery device. The lens looks like a regular 3-piece lens, but obviously what's unique about it is this silicone component with the UV absorbing macromers. The rest of the design looks pretty much like a regular 3-piece intraocular lens. The light delivery system looks, basically it's a slit lamp mounted on a table, which is connected to a computer, which has the UV light delivering system in it. In the computer, we enter what the patient's refraction is, what the desired refraction is, and it looks pretty much like a laser, although it is not a laser, it's just a light delivery system. Probably the most critical part of the success with this lens is very precise postoperative refractions, and that's where Sarah Fry and Rand Seekert come in and are very involved in the postoperative management of these patients. Refracting them, demonstrating what their refractive options might be, demonstrating things like monovision, mini monovision, blended vision, and then giving the patients a chance to see what they like and have the option of potentially changing their vision to that refraction. So in review, about 17 days after the patient's surgery, once things are stable, specifically with regard to wound healing, the lens is settled in place. We've done their refraction. We've decided what their target refraction is. We put them at the light delivery device, apply the lights to the lens. It changes the shape of the lens into the new refraction. And then we stop at this point and let the patients go for about at least 3 days with that refraction to see if they like it or not. If they don't like it, we come back, re-refract them, maybe change it to something slightly different. And when they do like it, we do a final lock-in, which basically seals the lens in its final position. And then the treatment is done. They can stop wearing the UV glasses. And that typically, again, is between 2 and 4 treatments, somewhere between 3 and 6 weeks post-operatively. A key piece, as you can guess, is they need to protect their eyes against exposure to UV lights between the time of the surgery and the time of the light treatments. So this is just a little animation we show patients about the importance of wearing the glasses and how to do it. So it's just a short one I'll show to you.
Congratulations on choosing a breakthrough option in cataract surgery, the Light Adjustable Lens. This lens is specially designed to be adjusted after your surgery using light. After your eyes have healed from cataract surgery, your doctor will be able to use ultraviolet light to adjust the power of your new lens. Ultraviolet, or UV light, is a wavelength of light that naturally occurs in sunlight. Your doctor has received extensive training on how to deliver the precise amount of UV light to adjust your lens. The sun, on the other hand, has received no training. Since being exposed to sunlight at the wrong time could affect your lens and your vision, your doctor will provide you 2 sets of UV protective glasses. Let's take a look at how you can keep the sun away from your lenses during a normal day. Good morning. As long as your curtains are closed, you don't need to wear your glasses when you're asleep. But make sure you put on your clear UV protective glasses before opening the curtains. There's also no need to wear them in the shower, as long as your bathroom windows are covered. Enjoy your morning coffee and catch up on the day's news with your clear UV glasses on. Because even if you're indoors, the sun's light bounces around interior spaces. People are often surprised to learn that the sun's UV light can still affect the light adjustable lenses when they are in the shade. So if you're outdoors, even in the shade or on a cloudy day, make sure to wear your tinted UV protective glasses and a hat. And wear your protective glasses at all times when you drive. Tinted glasses during the day and clear ones at night. A simple rule is, if you wonder, wear your UV protective glasses. Let the sun shine in all its glory, but leave the precise UV light adjustments to your doctor.
Alrighty. Now, not everybody is a candidate for this lens, and I'm going to go through some of the contraindications. So there are some medications which are UV sensitive, specifically hydrochlorothiazide, the antihypertensive diuretic, tetracycline, the antibiotic. Those, if anyone is on those medications, they need to be discontinued at least 5 days prior to the light treatment. Any medications which are potentially toxic to the macula, things like amiodarone, tamoxifen, hydroxychloroquine, phenothiazines, those are absolute contraindications. It's not known what the combined effect of the medications and the UV light to the macula would be, so it's just a no-go. Patients who have herpes simplex virus keratitis, there's a potential for reactivation of the virus from the light treatments. This is something that was figured out with the corneal cross-linking experience. It's not an absolute contraindication, but patients who do have a history of herpes simplex keratitis with scarring may need to be placed on prophylactic antivirals, and that's certainly something that needs to be discussed with them. And the last contraindication is patients with small pupils. As you can imagine, for this light treatment, you have to be able to visualize the entire optic of the lens, which has a diameter of 6 millimeters. So patients need to have at least 6.5 millimeter pupils in the dilated state, so we can go ahead and do the light treatments. So just to review again, the patient's journey. The initial journey, as you can tell, is pretty similar. They're evaluated, we counsel them, they get their surgery, and we really don't do much until at least 17 days postoperatively when they'll have their initial early post-op refraction. We typically aim for these patients to be a little on the plus side, like maybe plus a third, plus a half, and then we adjust the light treatment to their desired refraction based on their first consultation. And as I mentioned, that can be changed about 2 or 3 times until they're comfortable, and then at the 4th light treatment, it's locked in. The light treatments themselves, again, are done no closer than 3 days apart, just to give patients a chance to get used to them. Some results, some outcomes, and why is this such a valuable technology? You know, without the light adjustable lens, we're pretty good at treating averages, at hitting the target for the mean of patients. In fact, we know in our practice, when we go to great lengths using all of our equipments and formulae and the aura, we can get about 90% of patients within a half a diopter of targeted of our goal refraction, which leaves, you know, a significant amount who are doing well, but there's some who don't. And those are the outliers. So we can treat the mean, we can't necessarily treat the standard deviation. And the unknown variables, the biggest one is effective lens position. We never quite know where that lens is gonna sit in the eye. And also, even though our incisions are pretty small, some postoperative healing scarring may change the astigmatism slightly. Posterior corneal astigmatism is also known to be a significant factor, although I think we do a really good job of measuring that. Again, with this lens, those are inconsequential because we just see what the refraction is and then treat from there. The FDA studies on the lens looked at about a little under 400 eyes in the purple group, which are the light adjustable lens eyes, and about 200 eyes in the regular group. And these were just standard surgeries. And obviously the patients underwent the light treatments as I've outlined postoperatively. And what you can see is in the normal group, about a third of the patients achieved 20/20 uncorrected vision. In the light adjustable group, 70% of patients achieved 20/20 uncorrected vision. 2025, it was more like 91% to 2/3, and 20/30 was almost 100%. So these results are clearly, you know, very, very striking. Another trial was done specifically looking at patients with astigmatism, comparing the light adjustable lens to the Technis toric lens and the Alcon toric lens. We traditionally have used the Alcon toric lens in our practice. And again, with our aggressive measures, we can get about 90% of patients to see 20/30 or better. In this study, about 16% of patients did not achieve 20/30 or better. Again, looking at the light adjustable lens, it was only 1.3% of patients who didn't achieve 20/30 or better. Pretty amazing results. So the main advantage is just the accuracy, the precision, which again is quite impressive. In fact, in the FDA studies, they showed that when they compared the two groups, the patients who had the light adjustable lens saw almost as well without glasses as the control group did with glasses, which again is pretty stunning. There's a very interesting study done, a small study on patients with radial keratotomy. As you know, these are really tough because the corneas are so irregular. And what they did is they looked at 23 patients who had cataract surgery with a light adjustable lens. And soon after the surgery was done, before the light treatments were done, 48% of the patients were within a half a diopter of target. They then went ahead and did the light adjustable treatments and got 22 out of 23 patients to within about a quarter diopter of target. So clearly this is a great indication, allowing for some flexibility to change and get the results to be quite a bit better. As I said, this is very new technology. It was FDA approved just in the fourth quarter. We got our machine in December. We've done 8 cases so far, and we have a few more on the books. We're proud to be the first in Tucson, but you can see it's been pretty widely adapted across the country. People are going to jump on this technology. Let's talk about patient selection and who might be good candidates. Certainly patients who are the perfectionists who want to see very well, the hunters, the artists, the bird watchers, the OCD types who just want outstanding distance vision, they're great candidates. Again, patients with astigmatism, probably low to moderate amounts, up to about 2.5 diopters would be great candidates. Although we have learned that you can treat up to 4 diopters of astigmatism with the technique, but I think it's in terms of FDA approval, it's 2.5 or less, so we don't want to push that boundary. Monovision patients, again, another great group of patients, specifically because they'll get a chance to try it out. You can literally demonstrate the monovision, and if they like it, you lock it in. If they don't like it, you can reverse it and get them back to balanced vision between the two eyes. Post-refractive or irregular corneas, again, another great group of patients who are candidates because a lot of the variables, the guesswork is taken out of it. And of course, anybody could get it if they want. There is obviously an additional fee based on the fancy technology and the expensive lens. And we've kind of priced it in the same range as we've priced our premium presbyopia correcting lenses. Again, with regard to the important role of optometrists, and we obviously, as you know, have 2 in-house excellent optometrists who help us to see what the patient's refraction is, see what the desired refraction is, and program it into the machine to do the light treatments. Interestingly, again, in the United States, we've got the indications I've reviewed for you. In Europe, they've also got an extended depth of focus program. So you can take the UV light delivering system and basically put a multifocal pattern on the lens. We don't have access to that here, but again, in Europe they do. Again, I'll repeat myself. The nice thing about that is you can demonstrate that to a patient. They can see what it's like. And if they don't like it, you can reverse it, which is pretty incredible. Okay. That's pretty much all I had to say about the light adjustable lens. I wanted to give you just a brief update on our PanOptix experience. I presented that to you last time. As you may recall, that's the trifocal lens, which gives good distance acuity and acuity at 60 and 40 centimeters with minimal dysphotopsias. It's not no dysphotopsias, but it's minimal. And this has been strikingly well received. We've now done over 150 in our practice. We do have one patient who's not happy with the dysphotopsias, and we're dealing with that, but the overwhelming majority of patients really love this lens. Their response to it is strikingly different from previous designs. And we continue to be excited and offer this to people who want to dramatically decrease their dependence on glasses and don't have any contraindications. I wanted to just tell you about a couple of lenses that are in the pipeline. You know, we always think, what's technology going to look like 10 years from now? What are our phones and computers going to look like? And there's some really exciting developments in intraocular lenses that I wanted to share with you. The first one is one called Fluid Vision. And this is basically an accommodative lens. It has large bulbous haptics that are filled with fluid. It's a silicone fluid. And in essence, the principle of it is shown on the slide on the right, where when a patient accommodates, it compresses the peripheral haptics. The fluid is then squirted from the haptic into the optic, which bows the optic forward and allows for some accommodation. There have not been any human trials yet, but certainly in rabbit models, this does appear to be very promising in terms of being a very good accommodative lens. This one is also an accommodative lens, but what's unique about it is it has two components. The first piece is actually put into the capsule bag. All of this is done through a small incision. And I'm going to outline the first piece is this accommodative component towards the bottom here, which operates on a similar principle to the one that I just described. Again, with accommodation, there's pressure on the haptics. Fluid is kind of squirted into the optic, which bows it forward and causes some accommodation. What's different about this lens is that there's a second component where there's a second intraocular lens that is put in front of the accommodative piece. So you've got a fixed lens and an accommodative component behind it. And what is pretty amazing is if you can contemplate that, Herb, I keep losing my mouse here. Excuse me. That if we could use that light adjustable technology that we've just described to treat the front lens and then have accommodative potential in the back lens, we may well have a lens that can give us this precise, crystal clear vision of the light adjustable lens with adding an accommodative component. Again, these are just being treated in the lab on rabbits, but my hope and expectation is that within a decade, these kinds of lenses will be available to us. Another one that I wanted to mention briefly is the femtosecond laser, which you all have heard about, is now being used to treat intraocular lenses. And theoretically, you could take any pseudophakic patient and apply the femtosecond laser to the surface, the anterior surface of the lens, to change its shape and adjust refraction, put on multifocal patterns, put on toric patterns. Again, that's being done in research protocols. And I think at some point that may be available to us. The holy grail, again, in cataract surgery is to have a precise, accommodative, adjustable lens with no dysphotopsias. And hopefully by the time some of us need cataract surgery, that'll be what's on the menu. So in summary, again, we at Tucson Eye Care are committed to offering our patients the most up-to-date cataract surgery options. We've had very good experience with the PanOptix trifocal lens. We're excited about this new light adjustable lens. Again, it's early days for that. We continue to have good experience with torics, custom distance, custom near, monovision using the intraoperative aberrometer. And our standard cataract surgery also continues to be very successful with very low complication rates for all three of our surgeons, our cataract surgeons. Well, I thank you for your attention, and hopefully I've inspired you with this new technology, and I'm going to pause while we get the next speaker for you. Thank you so much.
Okay, hi, I'm Emily Wright. Thanks for joining us. Going to switch gears and do a talk on gonioscopy and why it's a critical tool for diagnostic insight and therapeutic decisions in the glaucoma patient. So this is not a talk about gonioscopy technique or gonioscopy grading. I want to throw a bunch of images at you to familiarize you with the landmarks of this exam. I know there's a broad spectrum among optometrists in terms of how often you do gonioscopy, but just kind of getting these pictures in front of you and looking at the different pathology is the idea here. So this is a wide open angle here and just really well delineated anatomy here. So most anteriorly, we have Schwalbe's line, which is pigmented in some patients, pigmented here. Going more posterior, we have the non-pigmented trabecular meshwork, the posterior pigmented trabecular meshwork, scleral spur, and ciliary body. And another technique that is really helpful, especially for the anatomical narrow angle patients, is to do a very thin beam and orienting it obliquely on the slit lamp and looking at the light reflection. So where the anterior and the posterior corneal light reflections intersect, well, that's where the endothelium and the trabecular meshwork are, that's the junction of Schwalbe's line. And that's what you're looking at and looking for whether the angle is open. So in this talk, my main format will be looking, I'll show you kind of clinical pictures, and then I'll show you the corresponding gonioscopy images. There's a wonderful resource online by Dr. Lee Allward of the University of Iowa. He's a glaucoma specialist and assistant professor, and most of the images are from this color atlas of gonioscopy. And it is available for free, actually, online as a PDF. So the main purpose, again, is to familiarize yourself with the anatomy and also to convince you, similar to how this donut hole is critical for this donut, why gonioscopy completes your glaucoma assessment of your patients. So looking initially at developmental abnormalities of the angle, primary congenital glaucoma. This is obviously an infant and external photograph, and we have ophthalmic eyes. You can see very cloudy corneas. Notice that the light reflex on the cornea is blunted. That tells you there's corneal edema. Remember, the clinical triad of these patients are photophobia, tearing, and blepharospasm. Usually patients are symptomatic by 3 months of age and diagnosed by 1 year of age. They also have an enlarged corneal diameter and hazy iris details, and they can get breaks in Descemet's membrane. So these are coined by the eponym Hobbs striae. And remember that these are either horizontal or circumferential. They're not vertical. If they're vertical, that's usually a forceps injury at birth. So this is a corresponding gonioscopy image in a PCG patient. The first thing to notice is that it's a hazy view. And in general, these angles are anomalous. So no well-delineated structures. Typically, you have a very flat iris insertion into the angle and a trabecular meshwork with very minimal or no pigments. And again, you may be able to see kind of Hobbs striae, and you typically have a cloudy view, and that kind of guides your surgical management as well, how cloudy your view is. This is a drawing, obviously, not a real photograph of a patient with aniridia. One thing to remember with aniridia is that it's actually a misnomer. There is always iris tissue present, and it's visible in gonioscopy. You can have an iris stump here, which is what you're seeing. And if you ever see a patient with aniridia, please do a gonioscopy exam, because it gives you a really kind of spectacular view of the ciliary processes and also the peripheral retina and the zonules. 50% of these patients develop glaucoma. They can also develop poor vision due to cataracts or foveal hypoplasia. And the mechanism of glaucoma is often angle closure, where the stump kind of rolls up into the trabecular meshwork. All right, moving on to closed angle pathology. This is obviously a slit lamp photograph looking at this obliquely oriented thin beam. The thing to notice here is that the mid-peripheral iris is very convex. This is iris Bombay. And notice that the central anterior chamber is deep. This is an external photograph. You see marked conjunctival injection. Again, a cloudy cornea. You see blunted light reflexes here, and that's due to pressure spike. And then this is a gonioscopy corresponding image. And what we're seeing in this sketch here is that the iris is inserting anterior to the intersection of the corneal light wedge, and that's indicative that we have angle closure here. This is a drawing of the same patient after a laser peripheral iridotomy. You can see that it's a little bit deeper, but this patient has developed scarring into the drainage pathway. You can see Schwalbe's line here, and then PTM, posterior pigmented trabecular meshwork, and there's some PAS or scarring into the drainage pathway. So 2 gonioscopy images here. The top left, this is a closed angle. This patient has had an LPI. So remember, patients may not necessarily deepen following an LPI. And an important skill to have on your gonioscopy exam is to be able to perform an indentation or dynamic gonioscopy. And the bottom right here, the examiner is putting posterior pressure on the cornea with the lens. This arrowhead is indicating a posterior depression of the mid-peripheral iris, but notice that they're here adjacent to the pupil and adjacent to the angle. We see what the classic double hump sign of plateau iris configuration. These patients are, the risk of acute angle closure is now less than 1% with iridotomy, but they are at risk of a chronic angle closure glaucoma. And this is just a drawing, again, of plateau iris configuration. You see a very flat iris extending from the pupil peripherally. Right before you enter the angle, you get a prominent roll up of the iris, and then a deep dive of the iris into the angle. And that's the classic iris configuration. This is a slit lamp photograph, and the thing to notice here is that the anterior chamber is uniformly shallow. In fact, we have lens cornea touch here, and that contrasts with iris Bombay and acute angle closure glaucoma, where you have a deep central anterior chamber. This patient has aqueous misdirection or malignant glaucoma. A gonioscopy of this patient, because everything is pushed anteriorly, gives you a very nice view of the ciliary bodies and ciliary processes. And a diagrammatic view with aqueous misdirection, the thought is that the ciliary bodies are rotated anteriorly, and instead of the aqueous humor going in the sulcus anterior to the lens, draining through the anterior chamber out through the angle, it's shunted posteriorly and pushing everything forward, including the vitreous body, the lens, the iris, and you have a completely collapsed and flat anterior chamber. This is a patient who has had, appears to have had cataract surgery. You see kind of some debris on the optic. And again, notice this convexity of the iris, that's iris Bombay. This patient has an inflammatory uveitic process and posterior synechia to the optic. This patient's at risk for acute angle closure glaucoma due to secondary pupillary block. Other mechanisms of secondary pupillary block, and a patient here has had presumably a complicated cataract surgery and anterior chamber IOL. If the entire optic of the ACIOL is covering both the pupil and the surgical iridectomy, then you can get a secondary pupillary block and acute angle closure that way. This is a drawing of an aphakic patient who actually has had prolapse of the vitreous body secluding the pupil and has developed a secondary pupillary block that way, they can develop a very sudden high pressure. They also need a laser iridotomy. This can happen in young aphakic patients with an intact anterior hyaloid. This is a histopathologic slide of a patient with an intumescent cataract. You can see kind of the liquid cortex here, and they're at risk of developing phacomorphic glaucoma. You can see the apposition to the iris here. This can become a secondary pupillary block situation. They need cataract surgery, obviously, or an iridotomy. Okay, this is a drawing of the iris extending anteriorly to Schwalbe's line. And you can tell because the corneal wedge, again, is not meeting before the iris inserts. This is peripheral anterior synechia, and this can happen due to a wide range of pathology. Here we see gonioscopy images. On the left, neovascularization of the iris and angle. If you get NVA into the angle, these patients will always scar over time, and you could see that here, no angle structures in this patient, and they're going to develop neovascular glaucoma. Looking here at the top left, we have a picture of a kind of beaten metal appearance of the endothelium. We can see this on the disease spectrum of ICE syndrome, which can either present as Chandler syndrome, essential iris atrophy, or iris nevus syndrome. This is typically unilateral, and this is specular microscopy of the endothelium showing in the same patient their normal endothelium in one eye and the abnormal shape and size of these endothelial cells in the eye with Chandler syndrome. This is a slit lamp photograph of a patient with essential iris atrophy. Note the displaced pupil, the stretch holes, and then a slit lamp photograph of a patient with iris nevus syndrome. Again, all part of the ICE syndrome spectrum. And all of these patients can develop glaucoma or have the propensity to develop glaucoma due to PAS or scarring into the angle, as seen here, as well as here. Notice in this patient with iris nevus syndrome, that nevus pattern is actually extending into the peripheral anterior synechia. Another slit lamp photograph of this is a 7-year-old boy, and note the vesicles on the endothelium. This patient has posterior polymorphous dystrophy or PPMD. These patients are also at risk of developing glaucoma. Another patient with PPMD with endothelial changes, and these patients can develop PAS as well into the angle. On this particular image, note the broad high area of PAS, and then in this area, the angle is actually open. You could see trabecular meshwork there. This is a drawing of a patient who has had filtering surgery, probably a trabeculectomy. The sclerostomy is slightly posterior placed. This is the surgical iridectomy, and their ciliary body incarcerated into the sclerostomy, probably reducing the filtration. It's always helpful to perform gonioscopy on patients who have had filtering surgery to see whether this opening is patent. This is a patient with clearly broad areas of high PAS. This patient has actually had laser trabeculoplasty, and unfortunately will develop high pressures, which obviously is the very reason that patient underwent the procedure. Moving on to open angle pathology, pigmentary dispersion syndrome. So you can see pigment on the anterior capsule. You can see kind of a puddling of pigment on the iris on slit lamp exam. This is the classic mid-peripheral transillumination defects. And this is a really beautiful photo, something that's not often clinically appreciated. This is called a Shea stripe, and that is pigment deposition on the posterior capsule where the zonules are inserting. And these are gonioscopy images of pigmentary dispersion patients. We have the thing to note here, of course, is the dense uniform pigment of the trabecular meshwork. You also have a pigmented Schwalbe's line, but also note the concavity or posterior bowing of the iris. And that is part of the pathology here. When this mid-peripheral iris rubs up against the lens, you get a dispersion of pigment That's what causes those mid-peripheral iris defects and the liberation of pigment into the drainage pathway, causing pressure issues, and also the pigment deposition on the capsule and the endothelium. This is another really just beautiful photograph of that pigment deposition on the posterior capsule in patients with pigmentary dispersion syndrome. Moving on, pseudoexfoliation. This is that classic appearance of pseudoexfoliative material in the anterior capsule. This is an aphakic patient with pseudoexfoliation on the anterior vitreous face. And as you know, these patients can get weak zonules and dislocation of either their native or lens or their implanted intraocular lens. On gonioscopy, you don't get quite as dense of a pigment deposition or as uniform as the patients with pigmentary dispersion, but you can get a great deal of pigment, and you often get this Sampolizi's line or pigmented anterior Schwabe's line. And you can also, on gonioscopy, often see pigment deposition in the sulcus on structures like the ciliary body, or here kind of like the frosted zonules. This particular patient has had a trabeculectomy, and you're using your gonio lens to look through that iridectomy into these structures in the sulcus. This is a right and left eye of the same patient. The first thing to note is heterochromia. This iris is relatively lighter, and this patient has also had surgical iridectomies, has had 2 trabeculectomies there. This is Fuchs heterochromic iridocyclitis. These patients can develop fine KP, and they typically have a stellate pattern like that. They can get neovascularization of the iris as well as posterior subcapsular cataracts. On gonioscopy, they can get neovascularization of the angle. And the thing to remember about these patients is they can develop hyphemas with intraocular surgery. They can also bleed with just gonioscopy. But interestingly, unlike other neovascular processes, these patients do not often or most times develop PAS or scarring into the drainage pathway. The slit lamp photograph, this patient has dilated, tortuous, corkscrew conjunctival vessels extending all the way to the limbus. They have a low flow dural sinus fistula, resulting in elevated episcleral venous pressure. And you can see this reddish hue in Schlemm's canal. And that's what to look for on gonioscopy in these patients. So moving on to traumatic sequelae, patients who have had trauma, gonioscopy exams are critical to look for foreign bodies and other pathology. This patient has had a blunt trauma, and you can see a sphincter tear here at 7 o'clock, and the corresponding gonioscopy image here. Not as impressive as some angle recession patients, but there is a slightly widened ciliary body band here. And these patients with angle recession are at 10% increased risk relative to the general population of developing glaucoma. This patient has had trauma also, and you can see iris disinsertion here. This is iridodialysis. A diagram drawing of this shows just the disinsertion of the iris from the angle, and you can see kind of the ciliary bodies or ciliary processes there. This is an OCT of the macula of a patient with decreased vision. You can see the choroidal folds here. And this patient presumably has hypotony. If you see that in a patient, you want to take a careful history, ask them have they had glaucoma surgery, have they had trauma. This is a great photo of a cyclodialysis cleft. So with the cyclodialysis clefts, you can get hypotony, a bright white stripe. You're looking at bare sclera just posterior to the trabecular meshwork. Also note this patient has significant angle recession. This is all ciliary body, and if you track that ciliary body along, it's just disinserting from the sclera right here, and the fluid is going through an area of low resistance, and it's causing hypotony and blurry vision. That's a drawing of the same thing. This is a histopathologic slide just showing the sclera, the ciliary body, the disinsertion. That's a cyclodialysis cleft. The other thing to mention, you're seeing patients after surgery, after glaucoma or cataract surgery. Gonioscopy is an extremely useful tool. If a patient has prolonged inflammation, you want to look for a retained lens fragment. Of course, following a trabeculectomy, as mentioned previously, looking at the sclerostomy to make sure it's patent. A lot of times patients may have vitreous to the wound after cataract surgery, and due to a dry eye or corneal pathology, you may not be able to see it other than on gonioscopy. I often do gonioscopy to look into the sulcus, especially after the patient has been dilated. It can give you a lot of information. For example, a patient who has inflammation and has had cataract surgery, if you suspect UGG syndrome, you want to look into the sulcus with your gonioscopy lens and see if that one piece haptic is out of the bag. Sometimes I'll even use gonioscopy to look at the toric marks if a patient's really slow to dilate or poor to dilate in clinic. And then of course, now that we have a lot of minimally invasive glaucoma surgical procedures, just being able to look into the angle and recognize these structures, or to see whether these devices, or to see whether they're in good position. This is the CyPass device. This actually creates a cyclodialysis cleft. Of course, this was removed from the market about 3 or 4 years ago now due to endothelial cell loss. This is a tube shunt in good position. Again, a gonioscopy exam of that patient. This is a drawing of a patient who has had a complicated cataract surgery and vitreous to the wound. Again, sometimes I have found that you can only recognize that on gonioscopy. Looking at iSense, the first generation had that tail and was only FDA approved for one. And the second generation is just kind of like a thumbtack, and you just kind of punch it in, you won't see a tail, and it's approved for 2. So there should always be 2. And then this is the Hydra stent. It's an intracanalicular stent that extends about 3 clock hours. So it's another device that you may recommend on patients who have had MIGS procedures. And then following a goniotomy procedure, you often see a bright white varosclera area where the trabecular meshwork has been unroofed. And then the last thing to mention, patients who have had these MIGS procedures can bleed back into the eye. And that I've seen patients years out who have developed, high pressures, and I don't see the blood until I perform a gonioscopy exam. And sure enough, if you look through that upper mirror, you see a little microhyphema, and that explains the pressure spike. So hope I've convinced you why gonioscopy is critical for your diagnostic assessment of your glaucoma patients. And again, this is the resource of most of these images. It's an excellent resource just to learn a lot about gonioscopy and really just glaucoma in general. Okay, thanks very much. Please stand by for Dr. Fry.
Good evening, everyone. Thank you for joining us. I'm Sarah Fry, and tonight I'm not talking about dry eye. I'm going to be talking about optical coherence tomography, or OCT. So I know we're all familiar with the technology. OCT is an imaging technique very similar, or analogous, I should say, to ultrasound, but it uses light rather than sound to image, to deliver cross-sectional images. And it's very useful to us in eye care because it enables us to image these subsurface layers that we normally wouldn't be able to visualize on our fundus exam. So just kind of the timeline for how OCT has developed over the years. It was initially conceptualized in the 1980s and then was further developed throughout the 90s. And the first commercially available device came to market in 96, and then adoption sort of followed that, and it became widely used in the early 2000s. So from the front of the eye to the back of the eye, these are the anatomical locations that we can use OCT for. For the anterior segment, we can visualize the various corneal layers in more detail. We can visualize the iris, and we can also take a closer look at the drainage angle. And so those are some applications, although it's obviously much less commonly used than the optic nerve and the macula. So just some background as to the time domain versus spectral domain OCT. They have some similarities and differences. Everything's kind of shifted to spectral domain these days. But time domain was kind of the original technology. They both use an interferometer to measure kind of the time delay between light entering the tissue and coming back. And but time domain uses a reference mirror. Well, they both use a reference mirror, but in time domain, that mirror is moved. Yeah. And so that information is collected as a function of time, hence the name. In spectral domain, the reference mirror doesn't move, and the information is read by a spectrometer.
You want toast?
So the traditional time domain technology was slower and had poorer resolution and only enabled two-dimensional views. So if we look at the image on the right, we have the macula being imaged with a time domain device up top and a spectral domain device on the bottom. And we can see that we get much better resolution on the bottom scan. We can clearly make out that epiretinal membrane, and we can more precisely make out that pseudo hole. So we just get a lot better detail with the spectral domain. Again, with the spectral domain, we have faster acquisition, we have better resolution of the images, and we also have image registration, which can be really important clinically when we're monitoring something over time. So if you think about CME, for example, and we're taking scans over time to check whether the condition is getting worse, better, or staying about the same, we want to make sure that what we're looking at is the same point in the macula over time. So if we're given a thickness reading, we want to make sure that we're comparing apples to apples. So that feature is really beneficial. Spectral domain technology also enables three-dimensional imaging, which is not something that we use all the time, but it is one of the benefits. So moving right along, I'm going to talk about OCT angiography next. And that is a non-invasive technique that's used to image the microvasculature of the retina and choroid, but not just those structures, essentially the back of the eye. So it looks at the moving red blood cells. And so the way it does that is it repeatedly images an area over time. And it looks at what's called decorrelation. So we look at that image over time and we see how much that image is changing. So if we see a lot of change between the scans, we can infer that the blood is moving through there. We're seeing a different appearance from one scan to the next because the blood is moving along. So we can deduce that there are high flow rates in those vessels. Conversely, if we see lower decorrelation, where every image from one time point to the next looks the same, we can infer that the blood really isn't moving very well, and there's a low flow rate in those vessels. So there's two platforms of OCT angiography: spectral domain, which is more commonly used in glaucoma, and swept source, which is more commonly used in retina because of its superior ability to visualize the choroid. So some advantages of OCT angiography are that it's a less invasive procedure relative to fluorescein angiography, which would sort of be the alternative to this. It involves less time to collect the data. It gives a quantitative analysis and is able to image all the retinal layers, and it's ultimately less costly. It has an upfront cost, but then the per scan cost is low. Some disadvantages is that it is more affected by patient movement. So patient movement can be interpreted as blood movement. And so that can sort of skew the results. And also, although we are obtaining a few scans, it's a relatively static point in time. It's a snapshot of time. It only takes about 10 to 20 seconds to get this scan. So we're really only getting that information for that period of time. So there are a lot of applications to OCT angiography. This is kind of a laundry list of some retinal applications to this technology. And these are just some scans on the right where we can see how we can visualize each layer individually. So whatever layer of interest, we can kind of focus in on that. This is a slide just showing various aspects of diabetic retinopathy on OCT angiography. Starting on the far left, we see cystoid macular edema with that green arrow. Moving along to the right with the blue arrow, we see some fronds of neovascularization. Then moving along with the red arrows, we see some areas of hyperreflectivity representative of microaneurysms. And you can see around those hyperreflective areas, there's some areas that are starting to lose vasculature. So some avascular areas are developing there. And then on the far right, we can see more pronounced areas of avascular zones are getting more pronounced on the far right. This next slide is talking a little bit about macular degeneration, and I just found out that Bob Snyder is going to be actually talking about this a little bit more tonight in terms of the application of OCT angiography and macular degeneration. But traditionally, we would monitor macular degeneration with regular OCT. And so on the top, we can kind of see from 1B to 1G how that sequence would go over time. So we don't really visualize overt subretinal fluid until we get to that 1E. But we can see if we back up to the scans on the bottom, these are OCT angiography scans, and we can see that there was some subclinical neovascularization developing before we were able to visualize fluid. So this shows promise in the potential for identifying the development of wet macular degeneration sooner. So OCTA also has some applications in glaucoma, and I know you are going to get a lot of glaucoma tonight, but I thought this was really interesting. On the right, we can see a scan for a normal eye on the top and another one for a glaucoma patient on the bottom. And I want to just draw your attention to that low perfusion map. And we can see in the normal patient, we don't have any areas of hypoperfusion. But on the bottom in the glaucoma patient, we can see that there are some areas where the perfusion is compromised. So they kind of, they're almost like nerve fiber layer defects, but they're just showing areas of low perfusion. And these have been found to show up before there are clinically visible nerve fiber layer defects, either on fundus examination or OCT. So there have been a couple of studies that have been done looking at OCT angiography and glaucoma. The first one looked at 3 cohorts of patients. There was a healthy group, some glaucoma patients before they had any visual field defects, and then a primary open-angle glaucoma group. The healthy patients were followed for 2 years, and the glaucoma patients were followed for 2.6 years. And the ganglion cell complex thickness and macular vessel density was measured over that time period. In all 3 groups, there was a decline in ganglion cell complex thickness and macular vessel density over time. But in the healthy and preparametric glaucoma, this decline was very small, it wasn't significant, and the rates were similar. In contrast, in primary open-angle glaucoma, the macular density, vessel density declined much faster than the ganglion cell thickness and was associated with disease severity. So that shows some promise in the monitoring of macular vessel density, particularly in more advanced cases of glaucoma. So this study sort of brought up some thoughts in terms of the other factors that could be responsible for the decline in vascular density. And so there's kind of one thought where high intraocular pressure causes neurovascular damage, and then that causes the vascular density decline. And another way to think about it could be that there are factors outside of intraocular pressure that cause the vascular density decrease first, and that vascular density decrease ends up causing neuronal tissue degeneration. So if it starts with a change in vascular density, then OCTA could potentially help us to develop targeted therapies in addressing this before there's structural change and vision loss. This was another study that was done with glaucoma and OCT angiography. And this was a study that looked at advanced glaucoma patients with very pronounced visual field defects. And these patients are challenging to monitor in that their visual field and OCT are already so, they've already experienced so much decline that it's really hard to appreciate any change over time because there's just very little structure or function left. So they used OCT angiography in these patients, and what they found was that there was no measurable floor. So meaning as these patients progressed, their OCT angiography declined, but it never bottomed out to a point where it couldn't be monitored anymore. And so that shows promise in providing another tool to monitor these advanced glaucoma patients in a better fashion than we can with our traditional imaging technology. So just to kind of summarize OCT angiography and glaucoma, it has been found to be very useful in showing these sectoral defects in macular vessel density before a clinically visible wedge defect on fundus exam or on traditional OCT. And so this can be very beneficial in potentially identifying glaucoma earlier. And then conversely, in our late glaucoma patients, OCTA may serve as a better way to monitor them when the other devices really aren't serving us anymore. OCT angiography is also thought to be a useful tool in treatment monitoring because it actually can improve. Unlike visual field or RNFL, we can actually see an improvement in angiography over time. So they looked at patients who had had a trabeculectomy, and they could see that their blood flow improved post-treatment. So that just kind of is a way to monitor and make sure that the treatment is on the right track. Of course, we need more validated normative databases in order to really use these tools in a widespread fashion. I'm not really going to touch on this, but OCTA can be used in uveitis. So moving along, another emerging technology in OCT is visible light OCT. It's an entirely different machine than OCT or OCTA. So whereas in OCTA, it's just a matter of buying some software for a lot of devices to be able to have that additional capability. In visible light OCT, it involves a different machine altogether. So it uses a different area of the light spectrum. It uses visible light rather than near infrared. And it basically has the capability of measuring oximetry. And so rather than just measuring blood flow, we're measuring the oxygen delivery to tissue, which is really more important in tissue health and disease. And I did want to talk a little bit about, there are some other methods of oximetry as well. These are not OCT per se. These are just devices that are on the market to measure oximetry, but it's kind of up and coming technology. There's 2 devices on the market and another one coming to market. And essentially, these are just additional tools to be able to measure the oxygen regulation in tissues. There are a lot of applications to this oximetry technology. It can be applied to kind of a group of diseases that are considered atrophic. And in these diseases, there's reduced oxygen consumption. And then oximetry can also be applied to ischemic retinal diseases, where the root cause of these problems is hypoxia. It's also being studied in conditions outside the eye, neurodegenerative disorders like MS, Parkinson's, and Alzheimer's, where oxygen dysregulation is thought to play a role. So those are all exciting applications. So just to summarize, OCT is really evolving towards examining more of the vascular aspects of ocular health and disease. And all of these methods show promise in the potential for earlier diagnosis and better monitoring of treatment. But we just need more research in order to know how to apply these technologies clinically. And one key component to that is going to be the validation of some normative databases. There has been some work, but we need more. Thank you for your time.
My sister-in-law sent me that joke in an email, and I promised her I'd use it in my next talk, so there it is. I'm going to go a little bit backwards in time on OCT, and I hope this information is useful to you. Glaucoma is a progressive, sight-threatening disease, as you know. So we're always looking for better ways to monitor its progress and assess the effectiveness of our treatment. We monitor the functional aspect of glaucoma with visual field testing, but this unfortunately is limited by being a subjective test and very often unreliable. Objective testing of physical changes in the optic nerve and retina have therefore become increasingly important in assessing progress in our glaucoma patients. When I was in fellowship training 30 years ago, the prototype Heidelberg retinal tomography device had just been developed. Within a few years, this device came to market and fairly quickly gained acceptance in glaucoma circles as a means of quantifying optic nerve head parameters. It required drawing an outline of the nerve head by the device operator with each scan. The consistency of the imaging from that instrument was not great and limited its use in following progression. With improved technology, today's latest iteration of optical coherence tomography affords a relatively high level of reproducibility, making possible progression analysis. We've long known that structural changes in the nerve occur well before functional changes are seen on visual field testing. In an autopsy study about 40 years ago, Harry Quigley at Johns Hopkins showed that half the fibers of a human optic nerve could be lost before glaucomatous field change occurred. Therefore, it's possible to detect progression at the level of the nerve structure prior to a patient developing any visual field defect from glaucoma, and possible to see the nerve changing before a field defect goes from bad to worse. This knowledge can lead us to changes in treatment to prevent loss of vision. OCT devices are available currently from several manufacturers, Zeiss and Heidelberg being the standards for glaucoma and retina. I'm going to be referring to imaging from the Zeiss Cirrus, which is the most commonly used instrument for glaucoma and the most extensively reported in the literature. In imaging glaucoma-related changes in the eye with these devices, we are looking primarily at the thickness of the peripapillary nerve fiber layer and the macular ganglion cell layer from which the nerve axons emanate. Older studies indicated that the peripapillary RNFL showed the earliest anatomic changes associated with glaucoma, but there is increasing evidence that the ganglion cell layer may show thinning even earlier on. So in the coming years, you're likely to see increasing reference to macular changes in glaucoma. This is the typical RNFL report from a Zeiss Cirrus machine. It defines the edge of the optic disc at the end of the opening in Brooks membrane posteriorly. And from the center point of that outline, it creates a 3.5 millimeter diameter circle right here, which is the area used for retinal nerve fiber layer thickness measurements. The thickness is displayed on a blue and yellow color scale map that is referenced directly to a normative database. These pictures here. And the green, yellow, red scheme is used in the graphs to show relative thickness compared to a normal range. For the ENFOS map view, the dark blue is the thinnest RNFL and the red is the thickest. In the graphs, green represents the upper 95% of the normal range, yellow the lowest 1 to 5%, referred to as borderline, and red is considered abnormal, comprising less than 1% of normals. The top middle chart here shows average RNFL thickness for each eye, then a measure of asymmetry between eyes, and optic nerve head topography below that. The first graph below refers to rim thickness, but then you see the Tisnet map of RNFL thickness along the length of the measurement circle, and below that are pie charts of RNFL thickness. The ganglion cell layer of the retina is the thickest in the macula. Because of technical problems with ganglion cell reflectance, the Zeiss machine and others instead measure the thickness of both the ganglion cell layer and the inner plexiform layer combined. The same color scales are used as with the RNFL. On the left here, you see a very atrophic ganglion cell pattern with a horizontal raphe right in this area, suggestive of glaucoma. Here are pie charts below that again, and measurements of average and minimum thickness of the GCC for each eye, and below are B scans of the retina through the macula. In terms of making a glaucoma diagnosis, OCT RNFL average thickness measurements are over 80% sensitive and just under 90% specific at the 5% level or below, and about 65% sensitive, but nearly 100% specific at the under 1% level. Ganglion cell measures compare similarly. Incidentally, the Zeiss literature actually refers to these colors as orange and maroon, but I think it's more of a mustard yellow and maybe autumn red, so I'm just calling it yellow and red. The glaucoma progression analysis on the OCT Cirrus compares pixels from 2 baseline scans and follow-up thickness maps against test-retest variability. Mapped pixels exceeding test-retest level are color-coded as yellow at the first event in which change is seen, and in red if seen at consecutive time points, indicating a statistically significant change from baseline. This then requires 2 baseline scans plus 2 follow-up scans to confirm significance. This page of the analysis shows the 2 scans used to establish the baseline on the left here, and the 2 most recent follow-up scans, wherein you see readily that a nerve fiber layer defect has developed inferiorly. Rate of change in average thickness is shown as a graph. That's right here. It's also color-coded for changes, but the colored circles are very small, and it's easy to pass them over if you're not really looking for them. The second page of GPA information shows the 2 baselines plus up to 6 follow-up studies and more detail regarding changes in individual sectors. Progressive thinning on the deviation map can occur as widening or deepening of an existing defect or the appearance of a new defect. Once an area is shown as red on repeat scans, you may not see further change if you're only looking at the map, because the defect may only be getting deeper in the same area. To take it a step further, you can look down at the table and see if the numbers for that general area are changing. So looking at this again, these are the 2 baseline scans. And then in the first follow-up scan, you see the first appearance of this defect, and then it's confirmed in subsequent defects, but it doesn't really look like the defects are getting larger. But if you look at the table, you'll see here in the baseline scans, inferior quadrant thickness is 96 to 97 microns. But then in the first follow-up scan, it suddenly drops to 82 microns. And in subsequent scans, it's maybe a little bit thinner, probably not statistically significant at that level, though. The ganglion cell GPA is simpler, giving less numerical information in terms of focal change, but uses the same concepts as the RNFL GPA. Again, you see a horizontal demarcation of thinning, typical of glaucoma. Similarly, there's a second page for the ganglion cell. I mentioned earlier that there's evidence of macular ganglion cell scans showing progression earlier than RNFL scans. And here's an example of a patient showing significant changes 2 years earlier on the ganglion cell scan than on the RNFL. So you see the first change here in 2014 in the macula, but it doesn't show up until 2016 in the corresponding area in the RNFL scan. This is basically a summary of what I think the significant points are. Plus it shows you the retest variabilities at a 95% confidence level. You can see that the smaller the area of measurement, the greater the variability in retest values. In the process of reviewing scans, it's easy enough to look for the red highlights and point to those as evidence of progression. But there are a number of sources of error that should be considered before possibly telling a patient that their eyes are getting worse and committing them to more aggressive treatment. Signal strength is indicated at the top of the printouts on a 0 to 10 scale. Most authors recommend caution in using scans with signal strengths less than 7, and most reported studies are limited to scans in the 7 to 10 range. The GPA program won't use scans for baselines if their signal strengths are 5 or less. Unfortunately, in day-to-day clinical practice, many of our images are through eyes with cataract or corneal opacities or small pupils or axial myopia, all of which can degrade the signal strength and really challenge our technicians. In my own experience, signal strength scans around 5 or 6 are often pretty good, and there's recently a published paper from Johns Hopkins indicating that signal strength as low as 4 may be acceptable. In progression analysis, I tend to look at consistency in signal strength. In other words, if the strength is always 6, the scan findings are often reasonably consistent. But if the initial scans were 10s and then the current scan is 6, that last scan needs to be regarded cautiously because lower signal strengths tend to show slightly thinner RNFL measurements. The normative database for the series consisted of only 284 patients. The refractive error range was -12 to +8 diopters among those patients. The database has been widely criticized for years because it's small and because it's poorly representative of the RNFL distribution seen in myopic eyes. The superior and inferior RNFL bundles and their peak thicknesses are shifted more temporally in high myopia, and that shift may give a false impression of thinning compared to non-myopic eyes. You can see the arrows here pointing out in black where the normal peak thickness would be expected superiorly and inferiorly. And red is in this patient showing the peak thickness shifted more temporally, both superiorly and inferiorly. You might imagine that if the nerve fiber bundles were pushed more nasally, the red areas seen in the deviation map might disappear. Axial length related magnification also affects OCT measurements. The longer the eye, the thinner the RNFL appears, and the smaller the disc area. The opposite is true for high hyperopes. There's about a 5% underestimation of disc area and RNFL thickness measurements if the axial length is over 25 millimeters. There is no compensation for this in the current Cirrus OCT, and this is independent of the refraction itself. Patients who undergo corneal refractive surgery don't show change in RNFL measurements afterwards. In high myopia, it's not unusual to see missing data peripherally, which I think relates to loss of focus along the relatively flatter curvature of the highly myopic retina. Ganglion cell scans can sometimes obviate this kind of artifact, but you may find similar data loss on those images as well due to staphyloma. Media opacities such as posterior vitreous detachment will cause a black spot of data loss. And if this occurs within the measurement circle, it generates a falsely thin measurement. So this is a good example where you see the PVD right here, the shadow of it, but it's not within the measurement circle, whereas down here it is, and here's the defect that it's caused. And in this case, well, you don't see a defect here temporally, but you do inferiorly. And comparing it to the first scan, it's pretty clearly caused by the PVD. Cortical and posterior subcapsular cataracts can cause artifactual thinning also, but nuclear cataracts not so much. One study showed about a 5-micron increase in RNFL measurements after cataract surgery. I seem to have missed a scan here. Oh, there it is. OCT scans actually consist of thousands of single A scans adjacent to one another. The Cirrus does 27,000 scans per second to produce a 6-millimeter cube of data. Eye movements and blinking can disrupt the alignment of the A scans and sometimes cause measurement errors. Motion artifacts are easily seen as breaks in retinal vessels. You can see in here pretty well, and similarly on the left eye. In advanced glaucoma, average thickness measures may not show significant change on OCT imaging because of what's been termed the floor effect, which Sarah mentioned earlier. The thickness appears to stabilize at a very low level, but is still measurable because of the presence of supporting glial cells and blood vessels within the measured layer that don't degenerate, as do the actual ganglion cells and their axons. The floor is around 50 to 55 microns for the RNFL, and in ganglion cell scans around 45 microns. When the floor is approached and there are relatively few ganglia and nerve fibers left, it actually becomes more useful to be following change in visual field testing than in OCT findings, like back in the good old days. The visual field may show progression while the floor is stable because the floor is not going to change. I'm usually pleased to tell patients that their scans are stable, but not when the average thickness is in the 50s. Normal age-related atrophy is a consideration also. Aging causes a decline in average RNFL thickness of about 0.5 micron per year, and an average ganglion cell thickness of about 0.3 microns per year. Whereas in glaucoma patients, on average, the decline is about 1 micron per year, but can be much higher in progressive disease. Artifactual thickening of the RNFL can be seen in the presence of epiretinal membranes with gliosis of the nerve following an infarct or following chronic papilledema, in the presence of active nerve or retinal edema, and with myelinated fibers, as you see in this slide. Artifactual thinning on ganglion cell scans can also be seen with outer retinal disease, such as macular degeneration, and in some cases will cause a so-called propeller sign with radial bands of thinning, as you see here. In my own process of reading the GPAs for RNFL scans, first I look at the pattern of thinning on the current map, also checking for artifacts and signal strength. Next, I look at the average thickness. If it's green, that's good. The patient probably isn't blind from glaucoma. Then I look at the rate of change graph for the average thickness. If it only shows 3 measurements or less, it won't be statistically significant. But if it looks like the rate of change is -2 microns per year or a higher absolute value, it raises my concern about possible progression. If you see 4 or more measurements, you can look for the tiny colored circles on the graph as an aid in judging progression. Next is the deviation map, which I find extremely helpful in looking at focal areas of progression because you can readily see the yellow and red areas pop up. The second page of the printout is more useful in terms of the extent of data displayed. Again, if you have only a few tests for reference, you can attempt to make an educated guess based on the numbers and your recollection of test-retest variability for each clock hour on the scan. But we can't say too much about statistical significance until we have 4 or 5 scans at hand. Then I try to convince myself whether the patient is really progressing or not, taking into consideration, again, the artifacts and signal strengths, IOP control, visual fields, and whether any other ocular pathology present might affect the information I have in front of me. The bigger message here, again, is that optic nerve and macular ganglion cell structure may change prior to detection of visual field change. OCT scans can detect these changes before your patient loses vision, so it's important that we make the best use of these tools. That's all I have. Happy New Year.
Well, good evening. Being last probably has some value. Not sure what it is, but I'm happy to be able to address you tonight. We're going to give you another update on the macular degeneration saga. That's been the kind of the focal point of research for me for the last, over 10 years now. But we're moving along pretty well now, I think. So hopefully you'll enjoy this. What we're going to talk about now is a trial that we're going to lead up to, and then talk about a trial that we've got for preventing vision loss from macular degeneration. As you know, neovascular macular degeneration is a leading cause of vision loss in the United States, and certainly prior to the use of anti-VEGF injections, it was the overwhelming cause of decreased vision in macular degeneration. Approximately 90% of all vision loss was attributed to neovascular macular degeneration. In the US, there's an estimated 200,000 people with new wet AMD each year. Probably 1.5 to 2 million people in the United States that have chronic wet AMD. Once you have it, it's pretty typical that you always have it. And Europe has very similar numbers. As the population ages, neovascular macular degeneration also increases, and the overall number of people with NAMD is expected to double from 2016 to 2050. So it's here to stay, at least until we get this new treatment going, I hope. The current treatments, as you're all aware of, anti-VEGF medications, these really revolutionized the treatment of neovascular macular degeneration. It started about 15 years ago and has attributed to a significant drop of legal blindness with people with neovascular macular degeneration. In the CAT study, which was a large comparative trial for anti-VEGF therapy, about 34% of the patient gained 3 lines of vision or 15 letters in visual acuity at an average cost of $23,400 in the first year, while only 6% lost 3 lines of vision. The vision gains are not always stable. A 5-year follow-up of that same CAT study showed that the mean visual acuity declined to 3 letters or worse at baseline and 11 letters or worse than at 2 years. So it's not stable, not necessarily stable. The injections are very expensive. I apologize if you can't read the detail on this graph, but the key here is this large sort of reddish clay-colored line. Anti-VEGF injections cost approximately $8 billion in the US alone, and that was actually a few years ago. They're the number one cost item in Medicare Part B. The injections and medication cost up to $2,300 each. They're repeated 7 to 8 times per year. In the clinical trial that I'm going to show you some of the data from that, we had one patient that had 92 injections over a number of years. And as you can see in that red clay colored line, total Part B spending is estimated to go up close to 18 to 20 billion dollars by the end of this year. Anti-VEGF injections also have a big personal toll. And that's probably due to the invasiveness of the procedure and fear of the needle coming at you and into your eye. For some people, their lives seem to revolve around having these anti-VEGF injections and what the schedule is. And it can become disruptive to other activities and plans. And they really have to plan for the clinic visits. Not only do they have to plan, but they usually have to have somebody take them there. Recent studies have found that patients with NAMD are often undertreated. And as a result, their visual potential may not be optimized. About 50% of patients miss clinic appointments, while another 20% or more had gaps of more than 100 days in between clinic appointments. Another study found that approximately 20% of patients were lost to follow-up, and this resulted in associated vision loss. In view of the overall treatment burden and cost and personal toll for NAMD, there's clearly a need for a preventive treatment, and preferably a pill or a drop form. And this is just a overview of people that are getting injections and what this personal toll is. People that say they're uptight, they can't relax, they found it difficult to think about anything but the injection as it gets close to the time of having an injection. Affects their sleep, affects their short-term memory, and some people also feel they have shortness. Their tempers are shortened and they are snappy, headaches, etc. So there's a lot of just an emotional overlay with this treatment. AREDs may reduce the risk of developing NAMD. Despite the widespread use of AREDs and advocacy of AREDs, the incidence of NAMD continues to rise. So it's not the panacea, and there's a need for a more effective prevention and treatment. So this is probably the key slide to understanding the first key slide to understanding how we're going to approach this. Neovascular macular degeneration is stimulated by VEGF. That's why anti-VEGF, which are antibody fragments to this vascular endothelial growth factor, work. Now, VEGF is secreted on the basal side of the RPE cells, and this schematic drawing shows the overlying photoreceptors, the underlying area of RPE cells, and then Brooks membrane, and then underneath this is the choriocapillaris, and that's where you get the first new blood vessels that are growing. And I think the key to take home from this slide is that these RPE cells have tight junctions. And so they secrete VEGF mainly out of the basal side, out of the bottom side into the choriocapillaris. And because they have tight junctions, anti-VEGF is not going to be effective at decreasing VEGF underneath the RPE. It's not going to get through these tight junctions. Very little will get through the tight junctions other than water and some ions. So there's been trials where they've tried to inject anti-VEGF in patients that have higher risk of developing neovascular macular degeneration, and they've been unsuccessful. Now, the receptor that we were interested in was one that was discovered at the University of Arizona. It's called GPR143 by Brian McKay. He didn't discover the receptor, but he discovered the ligand for it. And it's on the surface of the RPE cells. And L-DOPA, which is a common drug that we use for Parkinson's disease, is the endogenous ligand for GPR143. What does that mean? That means that the receptor GPR143 has arms that stick out from the surface of the RPE cells, and L-DOPA, which is made by RPE cells, feeds back onto these cells and binds to this receptor called GPR143. And when it does, binding of L-DOPA to GPR143 shuts down or reduces significantly VEGF secretion. If these cells are hypoxic, it'll decrease VEGF secretion. And it also decreases exosome trafficking in these cells. So VEGF is present, GPR143 is present on RPE cells. During certain times of the day, RPE cells make melanin, the pigment that's in the back of the eye, and the intermediate in the pigmentation pathway is L-DOPA, and that can feed back on itself and cause decreased GPR 143. And dopamine, which is can be a product of L-DOPA. Dopamine binds GPR 143 as well. And when dopamine binds GPR 143, it stimulates VEGF. And so you've got sort of what we call a yin-yang relationship here. If you've got a preponderance of L-DOPA, it's going to shut down VEGF. If you've got a preponderance of dopamine, it's going to stimulate VEGF. And that led to a hypothesis and actually a patent that had to do with the circadian rhythm in the retina, and our finding that dopamine and L-DOPA have this yin-yang relationship with GPR 143 and VEGF release, and that melatonin also plays a role in this process. And I'll get into that in two or three more slides down. And we hypothesize now that a combination of L-DOPA, carbidopa plus melatonin will be effective based on the following evidence. First of all, this is a slide that some of you saw 10 years ago, or 9 years ago, I guess. Actually not that long ago, but anyway, 5 years ago. So this was looking at patients that have Parkinson's disease, and if they do get macular degeneration, do they get it as the same time as somebody that doesn't take L-DOPA, and is the odds ratio the same? And it turns out if you have Parkinson's disease and you compare people with Parkinson's disease to age-matched controls not taking L-DOPA, that the people that take L-DOPA are less likely to get wet macular degeneration with an odds ratio of 0.65. And if they do get it, they get it 5 years later if they're taking L-DOPA than if they didn't. So that's the first piece of evidence. And that was from a very large data set, a data set of 90 million people, which had 12,000, I think it was 12,263 that were taking L-DOPA, and then with their age-matched controls. So then based upon that data, we had a couple of years to figure out how do we do a clinical trial to show if we can get an effect of L-DOPA on people that have neovascular wet AMD. And it wasn't an easy, what is a good endpoint? And so we finally hit on just looking at the fluid in patients that have newly diagnosed neovascular macular degeneration, and following it for a month and treating those patients with L-DOPA and no injection. And it took a while for us to convince some of the local guys to help us with that. But Cameron Javid was extremely helpful. He understood the science, and we started out first with some studies of patients that already had wet AMD and were getting injections, and showed that we could markedly reduce the number of injections they needed, and it was safe. It didn't, they didn't get sick, and their wet AMD didn't get worse. And we had done about 15 of those patients, and then Cameron came on board and started referring occasional patients that had new onset wet AMD, and we put them on L-DOPA, carbidopa, and followed them closely. We followed them every week for a month, and if they and after that month, if they wanted to, they could get injected. If they wanted to continue and they were doing well, if they wanted to continue on the L-DOPA, carbidopa, they could do that. But again, we thought it was safe, and we followed it very closely. And if you look at this slide on part A, it just shows that people that took L-DOPA, carbidopa had a statistically significant improvement in visual acuity. It wasn't great. It was just a few letters, but it was a little better. If we look at B, we looked at the mean change in the central retinal thickness. And this maybe isn't the best indicator either. This is just looking at a circle around the macula that's about 1.5 millimeters, and that's the central retinal thickness. And it looked at the improvement, and we've got the majority of them improved in the central retinal thickness. If we go down to, which suggests that there was decreased fluid, but the key was when we go down to C, we looked at the change in retinal fluid. Actually, if you had an area of OCT that had subretinal fluid, we could measure that and come up with an estimate of the area of fluid. And the majority of those patients decreased by 4 weeks, and some of them as early as the first week. And then in D, if we look at the percentage of change in retinal fluid at 4 weeks, any line going from the left downward to the right is an improvement. And again, the majority of those patients improved with L-DOPA carbidopa alone. And we just had this approved for publication a few months ago. And now we have the reprints. I've got some sitting on my desk, and reprints of this paper. And actually, I'll try to send these out to those of you that may be interested. And so we felt that we had good evidence now that we had a positive effect with L-DOPA carbidopa. So now we've added L-DOPA carbidopa and melatonin, and we're going to be probably looking at that in the near future. And I'll give you the rationale for that. So first of all, you've got L-DOPA, we know is the active ingredient that binds to GPR143. Then you've got this drug carbidopa. And what carbidopa does is it blocks the peripheral metabolism of L-DOPA to dopamine. So if you were to take a pill of just L-DOPA alone, some of that L-DOPA will turn into dopamine, and then that can raise your blood pressure, give you dizziness, and some other side effects. And because it's converted to dopamine, it's not available to get across the blood-brain barrier into the CNS as L-DOPA. So L-DOPA is for Parkinson's patients, L-DOPA is a prodrug for dopamine. It's taken by mouth, it's absorbed into your intestines, and then it gets into your bloodstream, and it's transported across the blood-brain barrier into your brain. If you if you took dopamine, it would be pretty toxic. It would have a lot of blood pressure side effects. So you can't take dopamine like that. And if you take L-DOPA and you take it with carbidopa, you increase the amount of L-DOPA that gets into the brain because you prevent its peripheral its decarboxylation to dopamine. And so it's very effective at increasing the amount of L-DOPA in the brain and in the eye, because it's the same mechanism of getting into the brain or into the eye. So that's why we use carbidopa. And every formulation you see of L-DOPA that's used for Parkinson's has carbidopa with it. Now, melatonin is a circadian signal, and melatonin is what you secrete. Your pineal gland secretes it as you're, about an hour before you go to bed. You have an initial spike of melatonin. It drops down a little bit, and then as you fall asleep, the amount of melatonin increases, and it peaks about 3 a.m. and then starts to drop back down. And melatonin is a circadian signal. So what it does, it shuts down dopamine release that happens in the eye during the day. So melatonin shuts that off. It shuts off dopamine release and resets the circadian clock both in the eye and peripherally. And since dopamine binds GPR143 to enhance VEGF secretion, melatonin via dopamine downregulation should synergistically reduce VEGF. And we validated this in an RPE cell culture continuous perfusion system, alternating L-DOPA and melatonin supplementation with dopamine, and we could get the VEGF to cycle in a circadian manner, in a diurnal manner. And then we submitted a US patent on this, and it's now filed and is published for using L-DOPA carbidopa melatonin as a unique new drug for AMD. And not only that, but it gives us new patent protection. And because it's a combination, it's a unique drug. And ideally, we'll get a pharmaceutical company more interested in developing it. Pharmaceutical companies are not terribly interested in repurposing generic drugs because they don't think they can protect their intellectual property, and they don't think they can protect their product, and people will just undercut them if it works. And so now having a new product with a new patent, I think, is going to be the impetus we're going to need to get it to move this forward. So next is just a slide looking that was part of Rory Calhoun or Rory Colvin that he and a number of us, this was done in Brian's lab, and I had helped develop this continuous perfusion system. And the bottom line is we can see the cycling of VEGF with L-DOPA, carbidopa versus dopamine in a circadian manner. And I apologize for the size of those individual figures, but it does cycle, and you can show the effect of these individually as well. So the reason you have to do a continuous perfusion, and that was actually pretty interesting in itself. Remember, I told you that L-DOPA is made in the RPE cells and it cycles back on itself. So it's in this, what we call a paracrine. And a paracrine is a type of endocrine process, but it's one that's occurs over very short distances. So if you have a paracrine effect, in other words, this quote endocrine effect, you can't just leave your cells sitting in this soup for days and days and show a circadian effect. It's not possible, because you have to have continuous washout of the L-DOPA or dopamine to get this cycling. And so that's what the beauty of putting it into this continuous perfusion system is. It allows you to look at paracrine type effects that you couldn't otherwise look at. Okay, so now we're at the proposed study to prevent neovascular AMD. And we think that since L-DOPA, carbidopa, melatonin decreases VEGF, and that VEGF is what stimulates it stimulates neovascular growth underneath the retina, and then it busting into the retina and causing fluid, we believe that that we could potentially prevent neovascular macular degeneration. And once somebody has neovascular AMD, it's an easy endpoint to show that you can get reduction of fluid. That's a no-brainer. That's simple to do, as we did. But how do we investigate the prevention of it? Well, what we want to do is we want to prevent it from getting to showing frank exudation. But the problem is you need a relatively high risk group to do this effectively. Let me go back somehow. So what you need is an enriched pool of patients with NAMD to move this forward. Now, a minimally enriched pool are those who have wet AMD in one eye and dry in the other. And this population is known to have about a 12.5% annual risk of developing to NAMD in the second eye. So if we further assume that we want to have at least a 30% reduction in the conversion from intermediate AMD to neovascular AMD to be of any benefit, if you look at this, you plug the numbers in statistically, you'd need to have to do 1,413 patients in each group, one in the placebo and one in the treatment arm, or a total of 2,826 total patients at a cost of about $9 million for drug and study visits to have a 90% chance of finding a positive effect if there is one, and a 10% risk of having a statistically insignificant effect, even if a positive one really exists. In other words, we're talking about the power of a study to find a event or set of circumstances that occur. So how do you get around that? Because nobody's going to risk $9 million. Not a lot of people are going to risk $9 million on this project. And that is by enriching the pool further. So if we could enrich the study pool with so we have patients that have a much higher risk of converting from dry to wet in the second eye, then we can markedly reduce the size of the study population. For example, if we estimate 80% of the patients with non-enlarging, non-exudative NAMD in the first eye progress to NAMD in the second eye in 1 year, and we postulate that we can reduce the progression by 30%, then we only need 78 patients per arm. That's a huge difference from 1,413 patients. And I'll get into this. We'll go over this again because it's a little confusing what I just said, but we'll go over that again. So how do we find these patients that have preclinical, non-exudative, that are at high risk? Well, first, the OCT images, it's pretty obvious when you see these people. And is this showing up on the screen that they're looking at?
Yes.
Okay. So you can see people that have subretinal fluid. That's pretty easy to see. Well, now there's this OCTA, optical coherent tomography angiography. And I thought Sarah did a very nice job at highlighting that. And she had some pretty nice slides that showed these subretinal neovascular lesions that had expanded and were leaking. And what we can do with this OCT angiography is we can find lesions. This is an on-face image. In other words, it's like a flat image of like a slide that a pathologist would look at. And in gold here are these areas of vessels that have blood flowing through them, and they're different than the rest of the choroid. And these happen to be picked up by this OCT angiography. And what this OCT angiography is doing is it's taking about 100,000 pictures in a second, very fast. And then it can do the mathematical modeling of this, and it's actually seeing the blood corpuscles popping through these little capillaries. And after seeing enough of these, then it can come up with a predictive algorithm that says there's a neovascular frond there, and this is the size of this neovascular frond. And so we can identify these sort of lesions before, and this is regular OCT here, before they have fluid. Okay, so you go, well, that's interesting. Wow. So you can find them where they're small little fronds, abnormal fronds. Well, then it turns out if these abnormal fronds are growing, they will ultimately develop frank neovascular AMD, and that's what this shows. One that grew from this size to like 1.2 millimeter or micrometer squared, 1 million micrometers squared, 1.2 micrometers squared, and now it's leaking. And it turns out there was a study that Dr. David Wong did, and he showed that if you can identify these patients, then about 80% to 90% are going to convert to wet AMD in 1 year. And so we really glopped onto that. And this is a survival curve, basically, and it's looking at the time to developing exudative in eyes with and without non-exudative neovascular fronds. In other words, if you have one of these neovascular fronds underneath it and it's growing, they don't last very long. This is out at 10 months, and 80% of them now have wet AMD, versus somebody that doesn't have this non-exudative lesion, but they're at, quote, higher risk group. It's much slower progression. So then we did some statistics. This was our statistician or statistical consultant who did this. And he said, if we know what the conversion rate is, then we can come up with a power for a study to look for a preventive study. So if we know what the treatment conversion rate is, in other words, if you were to convert 80% of the time or 90% of the time, and we said we're going to try to prevent this 30% of the time, you could look at this graph right here. So now we're assuming that you've got 90% of the patients that we are able to identify will go on to get wet AMD if we don't do anything. And we're going to treat them either with a placebo, or we're going to treat them with our formulation of L-dopa carbidopa plus melatonin. And we think that we can get 30% reduction in the conversion from dry to wet. Now we only have to use, to do this, we only have to do 50 patients per arm of the study, 50 in the placebo and 50 in the enriched pool. And that means that it's a tremendous reduction in the number of patients from 1,413 that would have to do. And it's very, it's quite cost effective, and it's something we could do. We could even fund this potentially internally. So that's what we're really pretty excited about. And so we submitted an SBIR grant. I'm not sure we're going to get it on the first go around, but we're going to keep plugging at this. And we wanted to first we need to find out what the conversion rate actually is. Is it 70, 80, or 90% or 100%? So we're not sure. We're just one paper, and it's a smaller paper. So we want to develop and refine a potential criteria of high risk non-exudative NMAMD using OCTA to identify and reproducibly measure the size, growth, and vascular patterns of nascent NAMD lesions. By nascent, it means they don't have fluid yet. Then we're going to calculate the coefficient of correlation for each with the conversion to exudative. In other words, is it just a factor of the growth rate, which we think it is? It might be the size. It might be something like the vascular pattern, but which of these correlates with the conversion to wet AMD. And we will also target at getting being able to get these exams with high quality. And then we want to determine the conversion rate of 60 patients with NAMD over 1 year. And we figured if we did 60, we would have viable statistics. And then we use this data to design a phase 2 clinical protocol of oral or topical L-DOPA with melatonin to prevent or delay development of NAMD. Now, since these slides were developed, we're now in the process of licensing a drop formulation, which I think will be even more exciting to use on that eye. And we've good penetration with L-DOPA, carbidopa with a drop, and that's probably the direction we're going to go. And the market potential for this, first of all, the potential to help a lot of people is staggering. And then the market potential is also staggering. And so ideally, we hope we can attract a pharmaceutical partner with this. If we look at the annual sales somewhere around what they pay for AREDs, it's potential over up to $1 billion, close to $1 billion a year product. So we think that that's going to be suitable. So Larry said, I think we're going to probably close right now. We're going to thank you for attending. If you have any questions, you could always get in touch with me. I think Larry wants to try to wrap this up so we're done at 8 o'clock-ish. And I think we're about 12 minutes over right now. So I'm going to thank you. Larry, do you want to say goodbye to everybody?
Yeah, I will. Thanks.
Okay, very good. And don't hesitate to give me a contact. Give me a call. We've got a list of people that are on the line, and I'm happy to receive a call from any of you if you have any questions. So thank you very much.
Well, thanks everyone for your patience. I know it seems like a long program, but hopefully it was worth your while. Hopefully you were at home with a glass of wine, enjoying it on the sofa, as opposed to sitting in a dark room. We've decided to forego a formal Q&A session, but we do still welcome questions. The logistics of it seem a little overwhelming. So please, we're all available to you all the time. Many of you have our cell phones, which you can feel free to call or email or just call the office. We appreciate all the support and hope you found the material interesting. And we sad to say, but I think we'll probably plan another program in about 4 months or so, which we'll probably do in a similar setting. So good night to all. Thanks so much for your attention.